Checkpoint inhibitors. Immunotherapy, monoclonal antibodies to immune checkpoints that can cause immune evasion. BT1, program death 1, and CTLA4, cytotoxic T lymphocyte associated protein 4, have demonstrated improved outcome in a variety of tumors, notably melanoma and lung cancer. Demonstration of the efficacy of anti-PD-1 antibodies in the metastatic head and neck cancer, such as response to pembrolizumab after failure of chemotherapy in a large randomized study, and superiority of the nivolumab over investigators' choice of standard therapy, attest to the clinical utility of these agents in head and neck cancer, and which have both been approved by the FDA for refractory head and neck cancer. And more recently, pembrolizumab has been associated with a survival benefit in the first line recurrent or metastatic setting, in the resulting in FDA approval as monotherapy in patients with tumor positive for PD-L1 and combined positive score CPS, and with platinum doublet chemotherapy in the total population in the first line. For nivolumab, the approval was based on a randomized trial called Checkmate 141 in 361 patients with platinum refractory recurrent metastatic head and neck cancer, comparing nivolumab 2 mg per kg IV every 2 weeks versus physician's choice chemotherapy at standard dosing. And patients treated with nivolumab had a superior median overall survival. And the 1-year survival rate was 36% with nivolumab versus 16.6% with the control arm. Treatment-related grade 3-4 adverse effects were less frequent on the nivolumab arm. Patients' reported outcomes were superior on nivolumab arm. For pembrolizumab, the initial approval in the platinum refractory setting was based on demonstration of a durable objective response in a subgroup of patients in international multi-center randomized, non-randomized, open-label multi-cohort study. In Keynote 12, 60 patients with PD-L1 positive recurrent metastatic head and neck squamous cell carcinoma who were platinum refractory received IV pembrolizumab 10 mg per kg every 2 weeks with ORR of 18% and 25% in HPV positive and 14% in HPV negative patients. Median progression-free survival among 12 patients with unconfirmed response was approximately 14 months, and the most common greater than or equal to 7% treatment-related adverse reactions were fatigue, pruritus, and rash. Another non-randomized study, Keynote 055, patients treated with head and neck cancer refractory to cetuximab and cisplatin using 200 mg flat dose of pembrolizumab, and similar activity was seen. There has been a subsequent multi-center randomized trial intended to better evaluate the comparative efficacy of pembrolizumab to standard therapy. Keynote 40 compared pembrolizumab 200 mg flat dose to physician's choice chemo, that is docetaxel, cetuximab, or methotrexate, in 595 patients of recurrent metastatic head and neck cancer with the platinum refractory dose. The median survival favored pembrolizumab arm but was not statistically significant, and on average grade 3 to 5 toxicity were less common on immunotherapy arm. So Keynote 48, pembrolizumab was evaluated as the first line therapy in the recurrent or metastatic head and neck cancer. Patients treated patients were stratified to receive pembrolizumab alone, pembrolizumab with chemo, or cetuximab with chemo. As compared to cetuximab with chemo, pembrolizumab alone improved overall survival in the combined positive score, CPS score of more than 20 and CPS of more than 1 population. Pembrolizumab with chemo improved overall survival as compared to cetuximab plus chemo. So the response rate of cetuximab with chemo was superior to pembrolizumab monotherapy in the CPS more than 1 and CPS more than 20 population, and was equivalent between the cetuximab and chemo versus pembrolizumab with chemo in all populations. Progression-free survival was not improved with pembrolizumab monotherapy or pembrolizumab with chemo. Pembrolizumab monotherapy had more favorable safety profile as compared to cetuximab with chemo, while adverse events of grade 3 or worse were those leading to discontinuation of the treatment and death were similar to in the pembrolizumab with chemo versus cetuximab with chemo. So the recommended dose and schedule of pembrolizumab for this indication is 200 milligram administered as an IV infusion over 30 minutes every 3 weeks in combination with chemotherapy or as a monotherapy, or 400 milligram administered over 1 hour every 6 weeks as monotherapy. Ongoing evaluation of the checkpoint inhibitors in locally advanced disease in the neoadjuvant and adjuvant setting, as well as concurrently with the definitive chemoradiations, are being conducted. Novel immunotherapies, especially tailored to HPV associated tumors, is an active area of research, and this includes therapeutic vaccines and engineered T cell to enhance HPV specific T cell populations. Thank you.